Good evening, everybody, and welcome to this amazing Legs Matters event. As you can see, we are live on Facebook and lots of other platforms, and I'm absolutely delighted to be your chair for this webinar. The title of today's evening webinar is Act Now to Save Limbs and Lives, and it's really focusing on a case for change for immediate action in peripheral arterial disease. And I'd really like to thank our sponsors of this who's brought us together, and that is Shockwave. Shockwave are really passionate about actually increasing the awareness of peripheral arterial disease, thinking about the challenge of this condition because it affects so many millions of people across the world. And we really want to focus on how do we get people appropriately diagnosed, appropriately managed, and how can they get access to the right care at the right time. And today's webinar is a type of sofa event, if you like. There are 6 amazing colleagues I've got with me today, from members of across the multidisciplinary team and all our experts in their own field of peripheral arterial disease management. So we'd like to be here for you too. So if you've got any questions, if you want to raise any points, please add them to the chat or the Q&A box, and we'll try to get through these as the evening progresses, because we just want to make sure that we're hitting your spot too. It's rather a relaxed environment. We try to do these types of sofa chats rather than the presentation style to try to really get you engaged in terms of how you can be part of this journey and how this is really an ethos of what's behind Legs Matters themselves. We have an hour. And if any of you have watched me before, I will be quite a hard chair in terms of trying to keep my wonderful colleagues on time, because we've got a lot to get through and we've had a lot of pre-questions in relation to this. So please introduce yourself, tell us where you're listening from, because it's great to have some thinking about the faces that's listening to us this evening. So without further ado, we're going to start by setting the scene, if that's okay. All of this evening is about peripheral arterial disease. So we're going to start really at the basics and hopefully take you through that patient journey. So I would first like to welcome my esteemed colleague, Jane, to introduce yourself, and also just tell us a little bit, Jane, about what is peripheral arterial disease and what clinical presentations are we including in this. Jane.
Good evening, Leanne. Thank you. I'm Jane Todd-Hunter. I'm a vascular nurse practitioner based up in Cumbria and current president of the Society of Vascular Nurses. Great to be with you tonight. So peripheral arterial disease, what is it? Well, it's really a chronic atherosclerotic condition affecting the peripheral arteries, usually the legs that we're concerned about. And it's common and it affects around 20% of people in the UK over the age of 60. And it's caused by that buildup of fatty material, cholesterol, other substances collectively that's known as plaque. That latches onto the inner wall of the artery, causes an inflammatory response within the artery itself, and it continues to drive this process of the buildup of plaque. It narrows the lumen of the artery over time and reduces the blood flow. And when we're chatting to patients, we often use that familiar term of furring up of the arteries as we describe it. And it's this reduction in blood flow to the tissues, to the muscles, that causes the symptoms of peripheral arterial disease. And perhaps the most common classic symptom is that of intermittent claudication. And that's pain or cramping in the leg muscles on walking that eases with rest. Walking or exercise increases the muscle demand for oxygen, but of course that reduced blood flow from the narrowed lumen of the artery means that the oxygen demand can't be met. You get that buildup of lactic acid and it causes muscle cramp. Patients tend to stop walking because it's so painful. That allows the lactic acid to disperse. The muscles do recover, and the person after a short rest can usually walk again. The muscles affected are downstream of the stenosis or the blockage. And of course, if peripheral arterial disease progresses, symptoms will also progress and develop with that progression of disease.
Wonderful. Thank you, Jane, for setting that scene. So I just want to carry on that conversation really about this language that we often use within vascular, and welcome Niraj to the conversation. Niraj, if you could just introduce yourself, and if you could just tell us about who's at risk of developing this peripheral arterial disease. And Jane's already mentioned something called intermittent claudication, but what's the difference and what's the progression, if you like, if you progress from intermittent claudication onto more severe disease? Niraj.
Thanks, Leanne, and evening, everyone. I'm Neeraj Racine. I'm chair of the Circulation Foundation and a vascular surgeon in West Yorkshire. So, in terms of risk factors for peripheral arterial disease, those are irreversible, as in risk factors you can't do a great deal about. And as I well know, that's being male and getting older. So that's two of them. And then there's also family history. In terms of the reversible risk factors, those risk factors that you can care for and modify, the commonest are smoking, high blood pressure, raised cholesterol, and diabetes. And as Jane's already touched on, really, peripheral arterial disease it's a spectrum of disease. There'll be those who are asymptomatic, as in they don't have any symptoms at all. But if we were to scan a number of people of a certain age, you'd see that they do have some narrowings in their blood vessels, but it's not causing them a problem. The next stage, again, Jane mentioned, is intermittent claudication, a cramp, where every time you walk a certain distance, it's relieved by rest, is due to these narrowings, blockages in the blood vessels, but clearly there are other causes of leg cramps, but it's specifically that characteristic pattern that's caused by the arterial disease. And what I think Leanne was referring to is that actually at the end of the spectrum is CLTI. Now, CLTI is chronic or critical limb-threatening ischemia. This is where the process has become so advanced and so severe, the limb is threatened in the shorter to medium term, not immediately, but in the short to medium term. And the symptoms of that are more around pain at rest, and it can go on to cause ulcers or gangrene. And the reason why the language is important in terms of the terminology, it's to indicate when you arrive at a state of CLTI, it indicates the absolute need for most probably invasive treatment to save the limb. And also it highlights the timeframes in which we should act to do that. In CLTI, opposed to other points on the spectrum, where actually at other points in the spectrum, other treatments such as medicines, etc., may be more appropriate.
So Neeraj, can I just ask you a few more questions based on what you've just said? Do all patients who have peripheral arterial disease, do they always progress to CLTI?
No, it doesn't. And what we'll do is we'll come on to, and I'm sure we're going to come on to the treatments, the way you can help yourself, the way you can optimize those, or you can treat ideally those reversible risk factors. And if you do exercise, we're going to talk about where to exercise, how long to exercise, and treat those reversible risk factors at an early stage. Actually, you can either improve if you have claudication, the distance you can walk, or indeed it can stay stable. So it's the smaller majority that go on to deteriorate, or this minority. The majority, if appropriately treated at an early stage, will stay stable or indeed improve.
And I think that's really important from a patient point of view in terms of that little bit of reassurance that there's something this isn't inevitable, because many of our patients are worried about losing their legs. The chance of that happening in general peripheral arterial disease is relatively low. And there's a lot they can do to actually stop that pathway, if you like, of progression. That's brilliant. Thank you. So I'd like to encourage Joe onto the conversation. Neeraj has already mentioned the importance of exercise. So Joe, why do we encourage exercise, especially in patients with peripheral arterial disease and intermittent claudication?
Thanks, Leanne. Yeah, I'm Joe Casey. I'm a podiatrist based down in Oxfordshire, and I'm vice chair of the Legs Matter Coalition. Well, exercise in itself actually has a complete biopsychosocial approach to care, which actually is brilliant in terms of trying to build all of those areas together to best support the patient, especially when it comes to personalising their care. So why do we choose to try and encourage people or offer them the risks and benefits? And that's the clinical benefits of exercise are to improve pain-free, maximise walking distances, enhances muscle and gait efficiency, including strength. It stimulates collateral circulation, improves oxygen delivery, reduces cardiovascular risk factors by encouraging cardiac output, improves quality of life, mood, independence, social interactions, and is cost effective in first-line treatment compared to surgery and other medicines. It's recommended, of course, by NICE guidance. So as clinicians, we should be sort of considering offering supervised programs and suggesting the risks and benefits so that real personalised care approach, that patients can choose how they can exercise or what it is that they're capable of doing. And as clinicians, how can we best support them in enabling them to exercise? Because not everybody's able to go out and, walk down the high street, for example, but how else can maybe chairside exercises? What is it that we can do to best support it? I mean, the Circulation Foundation, Neeraj, as I know you probably know, has wonderful resources. In fact, I have one here. It's a little large. It's their Exercise for Intermittent Claudication poster. And I've actually had that in my clinic. And the amount of patients that have come to me and said, I've got pain in my leg. I was like, wow, like they're really wanting to engage with that poster. So if anyone's got the opportunity to download that resource, that's great. And of course, this month, Neeraj, we've got the exercise program, which is called the Body Walk. And anybody out there, you'll be pleased to know Legs Matter has a team event going. So if you'd like to go onto the Body Walk on the website and download, you can join our team as being part of Legs Matter. So the clinical benefits of exercise really does help try and improve the pain-free, if it's symptomatic, of course, the intermittent claudication, but it's hugely beneficial from that biopsychosocial approach.
Thank you, Jo. And then Mark, on to you if I could. I suppose many patients, when they're diagnosed with peripheral arterial disease, they're really looking at clinicians like yourself to unblock the arteries for them. But why is that really not encouraged for every patient? Why do we only intervene on some patients? And could you introduce yourself as well, Mark, before you start?
Thanks, Leanne. Hello, everybody. Good evening. My name is Mark Portu. I'm a consultant vascular surgeon from London, predominantly dealing with limb salvage, endovascular approaches, and preventing amputation. So, yeah, that's a good question. I think the answer to that is that absolutely every intervention that we do is a balance between the benefits and the risks. And it's really a lot more obvious and far less nuanced when dealing with critical limb-threatening ischemia, that if we do not intervene, then the symptoms are very severe, the risk of progression and limb loss is much higher, and there isn't a huge amount of controversy if the person is suitable for that treatment. We generally wouldn't argue that point. But it is far more nuanced when it comes to intermittent claudication, and I think the reason for that is because we introduced this element of quality of life in there as well. And that's something that is far more subjective. So to give the example of a patient of mine, somebody who was not in any way a critical limb classification, but he was a delivery driver for a very popular online retailer. And his livelihood depending on his ability to be able to perform his job. And it was his intermittent claudication that was limiting his ability to earn his livelihood, and as a result, his employment was under threat. So in those situations, the balance of risk-benefit is obviously very individual, but it is also very different from somebody who has a much more sedentary lifestyle. So in his case, we didn't hesitate. We intervened, understanding that if you were to look at this from a sort of clinical evidence point of view, that actually the people who go through the supervised exercise programs, who undertake the risk factor modification that Neeraj mentioned, that are on best medical therapy, stop smoking or otherwise, often do better in the long term than those who undertake these interventions. And it's who's to say what the effect is of actually altering the natural progression of the PID process through intervening. But the fact is that there is definitely, without a doubt, a benefit to the supervised exercise, and often I suspect in combination with interventions. But I guess the last point I want to make is if we were to perhaps discourage health on lifestyle improvements through just going ahead and angioplasting the vessel, what incentive is there now for us to stop smoking or to undertake less, helpful health practices? So it is a nuanced argument, but it's fair to say that if in somebody that has tried conservative measures and is still finding that difficult to live with, there is a conversation we can have.
So this leads us to a question that we've had by a public member by the name of Lynn, who's been diagnosed with peripheral arterial disease. She's been prescribed some medication and she's been told to walk. she has found that her symptoms have improved a little bit in terms of intermittent claudication, pain on walking. But she's really interested to know whether her disease is progressing or deteriorating. She feels like she's sort of been abandoned, if you like, without that support. What would your advice be to her, Mark?
I think this is the situation exactly kind of what I just alluded to, which is that follow-up is important. In these situations, then really the marker of progression is on the basis of symptoms rather than the pattern of blockage of the arteries, which in some ways actually bears no resemblance, really. So I would be less concerned with her angiogram or duplex imaging or otherwise. I'd be far more interested in what her symptoms are doing. But definitely there is the need for that ongoing follow-up, for these things to be assessed and to be discussed.
Yeah, and I think it's the access to the right clinician with the right confidence and the right knowledge is the thing that we really need to be improving for our patients. So finally, I'd like to invite my finally, but not the least, my esteemed colleague into this conversation, Martin. And Martin, please introduce yourself and your specific role and tell me from your own perspective, what's the most important management in patients with peripheral arterial disease, especially intermittent claudication?
Thanks, Leanne. My name is Martin Fox. I'm a community vascular podiatrist working in Manchester for the last 15 years, working purely with diagnosis, management and triage of people with PAD and chronic limb-threatening ischemia. So I work a lot with people with intermittent claudication. I think the most important thing, first of all, for management of patients with claudication is that we need to make better efforts to get PAD recognised as a key, common and equal member of the cardiovascular disease family, and ensure that we have lower limb vascular community sort of champions on the CVD top tables nationally to bake it in more strategically and operationally into healthcare provision, and then to commission accessible community-based exercise programs nationally. Then I think we've got public health awareness of PAD and intermittent claudication. We really need to get it on the same vein as we've had stroke awareness, heart attack awareness, buses, billboards, pub beer mats, cigarette packets, and not the scary pictures, but maybe the empowering messages around, do you get exertional leg pain? Did you know it could be arterial? Go and see your GP to have a chat about it. So that real awareness raising at that level, which we simply don't have with PAD as the Cinderella member of the cardiovascular family. And then it's about likening intermittent claudication to angina of the leg and getting understanding of that around it, emphasizing it can be easily, effectively treated by seeing a GP and getting moved into effective programs. We need to enhance patient understanding and co-ownership of this with us, the vascular community, all of the lower limb clinicians who are out there, who are our lower limb vascular champions but aren't always recognised as such, primary care and exercise stakeholders, with a focus on the key modifiable risks that we've talked about that can be managed as per NICE guidelines, but in a language that all can understand, with optimum lifelong treatment interventions and expectations around personal setting of targets, around medicines, exercise, smoking behaviours. And finally, we need to reduce the common perception and expectation of angioplasty or surgery being the primary or best treatment for claudication, with both the public and most clinicians still who will refer people to hospital vascular services. And this is really one thing that we see so much of, and clarifying that invasive intervention is reserved for people with chronic limb-threatening ischemia or severe or deteriorating symptomatic PAD. We need to do this by creating more PAD diagnosis and triage services and clinics in accessible community settings, e.g. community podiatry and nurse-led diagnostic clinics, as per the few successful models that have been developed UK-wide but are not universally occurring across commissioning at the moment.
Wonderful. Thank you, Martin. So I'm just going to do a couple of quick fire and we're just going to slightly move from the agenda to keep us on time. A quick question to Jane. Do all patients with PAD need to see a vascular surgeon, Jane?
Absolutely not, Leanne. They need to be managed well in the community and they need to only come into secondary services if there's no improvement with that supervised exercise programme and best medical therapy, or if the symptoms are progressing to a chronic limb-threatening ischemia.
Wonderful. So, Mark, if I could go to you, if that's all right. So today's event's all about this parliamentary report that's been published along with Shockwave to really try to raise this at the highest of level, that being the government. And so could I ask you a little bit to give us a bit of a background of how did this come about, and actually what are we trying to achieve, if you like, by such document?
You'll remember, Leanne, our trip to Parliament December of last year for a roundtable meeting, a combination of the cross-section of the great and the good, I hope, of UK vascular community, but also our opportunity to speak to parliamentarians. I mean, this was born about because of our concern really regarding PAD as a serious condition that it is. Arguably, I'd say the most serious condition that you've never heard of. Lacking the public awareness, exactly as Martin has said, and also I would say in the wider healthcare community. It's also really of concern to us just quite what the disparity is in the availability of treatment across the nation, the availability of certain technologies, the availability of access to these technologies. The difference and the variability of the country is something that is, drastically needs and urgently needs changing. And as a consequence, large numbers of people are undergoing potentially avoidable, unnecessary amputations, major amputations, with a significant impact on their length and quality of life. So the purpose of our campaign here was perhaps to try and provoke those who are in that political sphere into adopting a national strategy towards PAD, raising awareness both within the public in exactly the way that Martin put across, but also, if anything, being able to target those colleagues of ours within the healthcare community about early recognition and then appropriate referral. As much as anything, we really need to help standardize the provision of care across the country and make available these techniques and technologies with which certain parts of the country have access and others don't, which is wholly unfair and unacceptable in the 21st century NHS.
It's amazing, isn't it, Mark, that we talk about the NHS as being a national health service and only those that work within it know it's a postcode lottery is what it is. And that in itself is completely unjustifiable. So Niraj, as the lead of the Circulation Foundation and a very prominent vascular surgeon in this field, why do you think that we need this dedicated strategy for peripheral arterial disease? And then along with that, what do you think are the biggest barriers in terms of diagnostic and treatment from your point of view? Oh, yeah.
I was the one who did the classic, left myself on mute. Apologies for that. Someone had to do it. So I'll take that second question first, Leanne, because that leads into why we need a national dedicated strategy. And as Mark's already alluded to, the biggest barrier is actually awareness, both in patients seeking assistance and healthcare professionals identifying the signs and symptoms. And in terms of the impact it's had in my practice, quite simply, it has impacted patients to a point of their limbs being threatened at the time they present to us. I'm going to give you a slightly longer answer, but I'll promise I'll make up time with you giving shorter answers to the next questions, because I think this is really important about the national strategy. Peripheral arterial disease, as Jane described up front, is a process of atherosclerosis, furring or blocking of the arteries, as is coronary heart disease that causes heart attacks, as is heart of stroke disease. But if you look at the rates that that preventative medication is prescribed in those conditions, it's far more than in patients with peripheral arterial disease. And actually, patients with peripheral arterial disease have 6 times the risk of cardiovascular mortality if they have symptomatic peripheral arterial disease. Now, if someone has a heart attack, they invariably get referred into a cardiac rehab program. The same process happens in the legs, and these supervised exercise programs that colleagues have referred to are only actually available through less than 40% of the centres. People know if they've got chest pain, it may be a heart attack and cause 999. People know about the FAST public awareness campaign about strokes and to get to hospital, but there is not that public awareness for peripheral arterial disease, which can cost limbs and lives. we also know that there's lots of media coverage around cancer, but we know that if with patients with CLTI, unfortunately, the mortality related to CLTI is worse in a number of cancers, but peripheral arterial disease doesn't get that coverage. And the final thing is that if you look at national cardiovascular plans, the 10-year plan that's come out in areas of work at the moment, Chapter 3 of the NHS long-term plan, it's actually cardiac. In my interpretation reading, it is not truly cardiovascular. So I think if you look at all those examples, there's, as Mark says, as most people have said, most colleague panelists, there's a real lack of awareness, understanding, public awareness around vascular. And that's why I think there needs to be a national strategy to bring it up to par on things that have equal impact, are the same disease process, and actually can cost limbs and lives.
Wonderful, thank you. So Martin, can I just ask you, based on all that what we've been saying so far, many of us on this call are actually based within hospital. You're rather unique because you're based in that community setting. So I suppose a direct question to you is, you're really passionate, but how do we get that passion in other community-based colleagues?
I think we have to give a bit more permission and confidence to become community vascular champions, so lower limb vascular champions, to all lower limb clinicians. And I use that term loosely, so it's inclusive of anybody that assesses the lower limb, be it a GP, a practice nurse, but classically community nurses and podiatrists at scale, both in and outside of the NHS, are assessing the lower limb every day. And in relation to chronic limb-threatening ischemia and diagnosing it, I think we need to make that as simple as possible, because we talk to ourselves about it all the time, but the simple structured approach to what we call in Manchester the 3 Ps assessment, palpating pulses, listening to phases, and taking pressures at the ankle or toe, and in a sequenced way in 10 minutes. And the perception of time being a big barrier is huge amongst clinicians, so they lose the confidence and the ability to build it into their busy caseloads. But if you tell any lower limb clinician that they can do this structured, simple assessment, palpate, listen to phases, take a pressure within 10 minutes, then we've got the basis for clinically diagnosing chronic limb-threatening ischemia or excluding it in many, many patients who present with lower limb problems that may be quite vague initially, with pain or aching or swelling or discomfort. So I think that simple thing of chronic limb-threatening ischemia being any objectively assessed PAD plus a wound of more than 2 weeks, for example, would be a very simple go-to. And the National Wound Care Strategy is really the place where we're building on the idea of excluding CLTI in leg ulcer management, which is great, but we also need to get it going for any lower limb wound to think CLTI, probably before you think about dressing choice and other issues to do with the wound, because we get clinicians very hooked on wound bed preparation, dressing choice, that sort of thing, without having done the basic vascular assessment. So I think we need to keep it simple and structured. We need to combine the clinical picture and that 3 Ps assessment with locally agreed clinical thresholds for referral and triage and pathways. And we can use Wi-Fi as a clinical tool that crosses all boundaries between clinicians, between nurses, podiatrists and vascular teams, to be able to triage and stratify CLTI from the less limb-threatening CLTI through to the immediately limb-threatening CLTI very quickly, and to get that triaged in.
Okay, you've mentioned a lot of terms there, and a lot of acronyms that we will go through without a problem. So, Joe, if I could just bring you in on this, if I like. Martin mentioned pulses, phases, and pressures, along with Wi-Fi scoring. Where can members of the multidisciplinary team get education into all of this that Martin's just referred to?
Well, there's several places that you can get some education in vascular disease. So I think there's Birmingham University does a peripheral arterial course. The Royal College of Podiatry does a vascular course as well. University of Southampton has chronic disease management, and they're including vascular changes. There's lots of university courses that can help support it. There's also CPD. There's online learning. You can come through Legs Matter. I know people have YouTube channels. I think I'm trying to remember what yours is, Martin. What's your YouTube channel? Gosh. Oh.
Peripheral arterial disease made easy.
There you go. How could you forget that? How could I forget that? So there's all sorts of, but the other thing you can do is go to your peers. If you know somebody within a hospital trust, then go and ask, can I just come and shadow you? If you're sitting in independent practice, can you go and speak to your NHS colleagues and say, can I come and shadow you for a bit? What's the availability there? Build champions in your area. Legs Matter have champions program. If you want to be part of that, then become a champion in vascular assessment and help support others in learning. So there's lots of different ways that you can do it. It can be formal through qualifications. It can be informal through building confidence, capability. And then that will help support your 3Ps assessment and your identification of PAD changes along with the symptoms.
Thanks, Jo. So Jane, quickly to you then. So within this document, this parliamentary report, it talks about immediate action for PAD. What does that mean for you in terms of practical and clinical terms?
Leanne, I think for me it means about reducing delays in assessment, appropriate investigations, and obviously training for healthcare professionals at a primary and community level as well. It's about improved clinical pathways that we can put patients through from primary and community into secondary care. And I think I really appreciated what we heard about empowering our colleagues in the community setting, really to screen and diagnose patients more, and perhaps to start that risk factor modification early to improve outcomes. I think for me, it's about making every contact count. If you have an opportunity to assess a leg, assess a lower limb, then please take that. Please do our vascular assessment. And if you pick up any symptoms or signs of PAD, then please act on that with your intervention with therapy. And I think if we can do that early recognition, we get more effective prevention in the community. And hopefully that will reduce demand at the front end, which is where we tend to work. And plus allow patients to remain active and well. I think for us in hospital, immediate and practical intervention is about offering those hot clinics for patients to have quick access to. So for us as a vascular service, we need to offer clinics to patients where they have quick access into vascular for timely intervention and investigations. And I think, to be fair, we're seeing a lot of those now across the country, where patients can perhaps even refer directly into themselves, as well as our community colleagues. So yeah, it's about removing the barriers that patients have about accessing services, I think.
So I think that we're all in agreement. The management of peripheral arterial disease, the diagnosis, the awareness should be a primary care place, if you like. But for patients who develop any form of tissue loss or constant pain in their foot, that chronic limb-threatening ischemia, those patients need to be referred into a vascular service. Thinking about that group and specifically, I'd just like to ask Niraj and Mark, as surgeons in this field. There is so many delays in that system of trying to get that patient in front of you who is facing chronic limb-threatening ischemia. And what's the evidence in terms of wasted, not just time, but wasted money and resources? And how do we really start to shift that focus in NHS policy and the way that we view this as that urgent requirement for care? So Niraj, can I ask you first?
Yeah, so look, it's still, and I know it's focusing a lot, but as we described originally, PAD, peripheral arterial disease, is a spectrum, and we're focusing on that end of it, which is critical or chronic limb-threatening ischemia. But CLTI costs the NHS £200 million a year, and that's outside of the care of the wider PAD of the spectrum, so just that section of PAD. And now clearly, and it's obvious that the rehabilitation costs, equipment costs, carer costs, house adaptations for an amputee are much larger for those patients of ours in whom you can save the leg, intervene earlier, and actually, as we've described, may not even get to a point where they require invasive treatment. And that's the cost to the NHS. That's aside from the physical, psychological, and economic impact for the patient themselves and their family and carers. So for me, it's really important that the policies or national policy look to raise awareness, do that early screening and detection, smoking cessation, which has to be key, and then talking about secondary prevention and exercise. And just to pick up on a comment in the chat about deprived areas, I know the Circulation Foundation, I want to promote the CF, obviously, but seeing as the exercise infographic, seeing as the exercise infographic has been mentioned and something about the deprived area. What I will say is on the CF website, to address those health inequalities, the exercise infographic is available for free in 15 different languages. We all serve diverse communities, so please use that resource, which is free, to support colleagues from, or sorry, patients from all sort of ethnic backgrounds and reduce health inequalities. So ultimately, policy has to change to ensure a minimal amount of patients progress to a point of having a threatened limb.
Thank you. Mark?
I'm not wishing to sort of repeat much of what Neeraj just said. If we think about it like this, how much does it cost to remove a limb? The actual theatre time, the consumables, the sterilization of the instruments, what have you, doesn't cost very much actually, compared to an endovascular revascularization procedure where the consumable cost is initially very high. But that is missing the point, because none of these costs occur in isolation. The entire cross-section of that patient's journey has to be taken into account. And that would include things as obvious like length of stay. It costs so much money to be in a secondary or tertiary care environment. Then think about the impacts to society as a whole. Think about the costs, exactly as Neeraj said, in terms of the rehabilitation costs to that individual of having a major amputation. Think about their loss of economic activity, loss from the workforce, the dependency now, the requirement for social care that is required. This is where it becomes a very, very clear win for the revascularization attempt. This is where, however much I spend of taxpayers' money in an attempt to try and salvage the limb, if we're successful, we will always save money in comparison to major amputation. And that's before we even talk about the actual impact to the people, the real people that we're talking about. But in terms of what policy, I think that was the second question you asked, that I think would personally make the biggest difference. I don't know if the other panelists will agree with me here, but in some ways we have to always strive to put ourselves out of business. And that is that the actual preventative interventions are the ones that will pay off longer term down the line. And these are the very things that become so much more vulnerable to cuts or to service, cuts basically. These are the things that for me, exactly as was discussed, the diagnosis and early aggressive secondary cardiovascular preventative medication. We're not just talking then about the limb end of the cardiovascular spectrum. We're talking about the entire cross-section of cardiovascular disease. That, for me, will make the biggest difference.
Lovely. And just before you go, Mark, you mentioned early on about access for patients with really bad CLTI, about access to the right technologies. Somebody's just asked very briefly, what do you mean by that technology?
Okay, so something that we haven't quite gone into yet is really how we can approach, how Neeraj and I earn our livings, which is how do we restore blood supply to a limb, a foot, or otherwise. And the truth is there are any number of ways of doing that. They have to be tailored to the individual need of that person. It is an individualized approach. Sure, there are, preferences or otherwise from clinicians, but generally it is done on an individual basis, both on anatomy, but also on that person's fitness, longevity or requirement for that sort of longevity. And it's true to say that in some people, we may decide that the best option is for them to undergo the kind of procedures that I've been talking about, the endovascular procedures, the ones that involve wires and balloons and other technologies, rather than bypasses and surgical cuts, cleaning the artery out, patching it or otherwise. And the truth is that we really now are striving to do better at those kind of interventions, because for us, it's not just enough to open the artery and walk away. We have to make sure it stays open. We have to make sure that not only it stays open, but achieves our outcome, which is symptom relief and longevity of repair. It's no good if we have to just keep redoing it. Do you see what I mean? And in doing so, it is true to say that we will inevitably have to deploy wider technologies, which we can be very specific about if you want to be, that cost a little bit more money. But the overall aim is to spend less and to prevent major amputation. So in the long run, the aim is to save money and to restore function and prevent amputation.
And I think this links really well to some of the comments that Heather's put in terms of why a GP is reluctant to prescribe exercise. We've mentioned before, all of us who work in a vascular hospital would love to be out of business. And we could go out of business if we get the right tablets, the right amount of exercise and the right amount of health promotion out there in community settings. But there does seem to be a huge postcode lottery about who can actually access exercise programs again across the UK. But if I could just ask one of my podiatry colleagues that's on the call, we've mentioned actually about the importance of exercise, but somebody's put in, how do you balance that with protecting the foot in terms of offloading at times? Any of you two just fancy answering that one quickly?
Well, I'll come in on that one quite simply because I'm quite passionate about this, that the diabetic foot population with wounds has been historically advised to rest with a wound in order to help heal the wound. And yet we know the counter side of that is that if you rest, you're not exercising, you're not stimulating circulatory response to the wound healing and also cardiovascular health. So the effectively offloaded diabetes foot wound should mean that you can engage in reasonable amounts of exercise. And that would be low impact exercise, so not jogging around a track or on a treadmill, but for example, use of pedal machines, rowing machines, and upper body cardiovascular type machines whilst in an offloading intervention isn't beyond the pale. But we really haven't opened up this whole area and done some safe, structured research on what would be too much and what would be optimized. So I think it's a really key area, Leanne, where we need to merge the diabetes foot community with the cardiovascular community again about empowering safe, effective exercise in those with chronic wounds.
Yeah,
do you mind if I pop in, Leanne, on that one?
Yeah,
and just sort of add in that, we've spoken a lot about sort of all of the holistic workforce. And actually, this is where our physical therapists would come into play. So our physios to help us with things like strengthening, muscle, gait, as well as those offloading devices that Martin's been talking about. So that, there's a real multidisciplinary approach here that could be encouraged if, patients are living with plantar foot ulceration or foot wounds. Just to kind of really bring it all together. So I think that just complements what Martin was saying.
Mark?
Yeah, I was just going to say that this is very much illustrates where you should have good channels of communication with your vascular surgery teams. Because in a situation that Martin described there, that would be almost by definition CLTI. And we may very well, with assessment and investigation, consider that person a good candidate for a revascularization procedure, because it's not confuse our populations. The people that we're referring to supervised exercise is more of a longer term treatment for somebody that has got symptoms of exercise-induced pain. When it comes to critical limb-threatening ischemia, there's not, I would suggest, too many of us out there who would consider walking that off. So, as I say, that's very much a case of when to engage with your vascular surgery team.
I was thinking more there, sorry, to come in with the neuropathic wounds, Mark, where we've got a big population with neuropathic wounds who are simply being advised to rest, and then it becomes a rest for life prescription, which of course our neuropathic population die early of heart attacks and strokes as well. So it's just getting those nuances about how exercise can be empowering and achievable even for people with wounds. But yeah, if there's a primary ischemia component, that needs dealing with.
And we can't forget when we say exercise, often what we just mean is movement or something that gets you slightly out of breath. And we have to remember this exercise also is for the biggest muscle in your body, actually maintaining the heart, which is part of the cardiovascular disease that keeps you all healthy. Niraj, very quick question for you. How much do you value an ABPI? And I'd like you to take that both from a perspective of diagnosis of PAD and also the presentation of patients with CLTI. Niraj.
Okay, so I know this is a bit of a topic where people have different views, so I'll give you my personal view. And my personal view is I think it's a really valuable tool. I think it's a non-invasive, quick bedside test. It has been shown to be very sensitive and specific, and what I mean by that is that it's an accurate test. I believe that there's two things about it. Yes, it can classify severity of peripheral arterial disease, but it also detects and suggests the presence of cardiovascular wider risk. So we know that those patients suffer the extremes of ABPI, even when it's elevated, shows that those individuals are at increased risk of cardiovascular mortality. I think the other value of ABPIs is in that discrimination of diagnosis. We spoke originally, we're going right back to the start of this when we were talking about intermittent claudication, and I said that calf cramps can be due to lots of things, or leg pain or walking can be due to lots of different things. Actually, one of those things is perhaps pressure on the nerve in the back. If you were to do an ABPI and the symptoms weren't quite right and your ABPI was normal, that's actually reassuring as part of the process, the diagnostic process, to say, actually, this is or this isn't peripheral arterial disease. So for me, I personally believe that the ABPI is a really important tool, and it's a tool that we should be using far more than perhaps we do.
And I think it's about demystifying it. It's only a blood pressure. It's just a blood pressure of a leg.
Absolutely.
And I think that the more that we talk in that language, the easier it becomes. Martin, hold your horses for 3 seconds because we're running way over time at this moment. Jane, very quick question, if I could bring you in on this. All of that in terms of really important, but your patients will always be worried about losing their legs. How can we empower patients to be able to look at signs of chronic limb-threatening ischemia and that progression that's truly that they're worried about?
So I think, Leanne, we can empower patients to become experts in managing the peripheral arterial disease. We need to enable that, and we need to inform our patients of those potential symptoms and encourage them to seek advice early on. I suppose really what we need to do is give them the tools that they need to have conversations around peripheral arterial disease with the appropriate clinician. And what we find in clinic is patients often have multiple visits with their GP or with even a physiotherapist before they finally reach a vascular service and they get that correct diagnosis. So it's giving them the tools that they can have appropriate conversations. And I think as the SVN, we've recognised the need to safety net our patients with peripheral arterial disease. And what we've developed as part of our work this year is we've produced that little credit card size CLTI reminder for patients. So it's a little card that patients can pop in their purse, pop in their wallet, just as a reminder of the symptoms to look out for, such as rest pain, non-healing wounds, gangrene, infection. And if that happens to ring your clinician, be that primary care or be it your GP or indeed your vascular contact, ring them urgently and get seen within 5 days of those symptoms developing. Just a gentle reminder that time is absolutely vital for good outcomes, and they should be seen by a vascular specialist within 5 days. And really, we're hoping that that little reminder can empower patients to seek timely advice and treatment.
Brilliant. Thank you, Jane. So there's loads of questions. There is loads of questions about, Joe, you mentioned physical therapists doing exercise and your podiatry colleagues are saying, hang on, we do that too. I think that what we are here, we are a collection of nurses, surgeons and podiatrists. We're breaking down the borders. We don't care really who does what, to tell you the truth, so long as the person that's doing it is informed and giving the right advice. And so anybody with interest in this, you are welcome into this space to help to solve this problem. And there's a quick question from Catherine saying that should patients who's had coronary artery disease have an ABPI? Not really, Catherine, unless it's symptomatic by default. If you've got coronary artery disease, you can tell that you're going to have a degree of peripheral arterial disease. Those patients should already be on best medical therapy of modifying their diseases and the right medication. So I wouldn't worry about that set of patients. There is a question about a private podiatry practitioner trying to get access to learn how to do some of this. I know Martin will accept you. I know I'll accept you. Please reach out. You can come and spend a day with us. Even if you haven't got an NHS contract, you're not allowed to touch our patients, but you're more than welcome to come and visit our clinics and see what we do. So please reach out to one of us on this call. Time is running so quickly, you can tell because my voice has gone at about 100 speed. Okay, so I want very quickly towards the end of this, because it's going to be time to wrap up. So very quickly for all of you, what do you wish your colleagues understood more about PAD management? Quick fire questions. Niraj first. You're on mute again, Niraj, twice. Go on.
Speed of treatment required when a patient has CLTI.
Perfect. Joe?
Consider the human cost, the biopsychosocial approach and personalising the care plan to the patient.
Wonderful. Jane?
Vascular don't need to see these patients if they've got stable peripheral arterial disease. We don't need to see them. They can be safely managed within the community with exercise and best medical therapy.
Martin?
Claudication isn't usually a risk of amputation and can be managed as a cardiovascular disease, and non-healing wounds and CLTI needs to go to a vascular team quickly.
Mark?
Peripheral artery disease needs to be considered along with coronary artery disease and cerebrovascular disease and given equal footing.
Perfect. Gosh, I love your quickfire answers. So same again, if you don't mind. You have a lot of passionate clinicians who's taken their own time to join this call today, along with a smattering of patients. If anybody's listened to this, what do you think should be their immediate next steps in terms of helping to shape this future and raise this agenda? Niraj, you first.
I'm obviously going to say go to the Circulation Foundation website, use the free patient and healthcare professional resources that are there, and also use it to learn more.
Joe?
Well, I might actually mirror Niraj there, because I actually love the Circulation Foundation's resources. I use them all the time, but there's loads of other places. Royal College, Legs Matter, SVN, link it all together. Let's all just join this. We're all in this together. So you'll find information everywhere.
Jane?
I think make every contact count for patients' legs.
Martin?
Empower people around awareness of the Circulation Foundation infographic, and everybody who looks at lower limbs, get yourself a Doppler and a SFIG cuff as a bare minimum and get comfortable with using it so that you can get confident at vascular referrals when you need to refer CLTI.
Mark?
Peripheral arterial disease, risk factor management, check that they're on best medical therapy, and if not, ask why not.
Perfect. So a couple of answers to the questions. You can download the chronic limb-threatening ischemia cards that Jane mentioned from the SVN website. We'll make sure there's a link. There's a link now within the chat to be able to do that. We appreciate what we're telling you at this moment in time is sometimes not happening within your local area. That's the reason why we've all given up this evening to be here today. We need to improve this. We need to be shouting about it. We know about the postcode inequality, both of diagnostic of PAD and access to timely treatment for patients who's facing CLTI. We know this is driving up amputation rates, and this is why we're here. So we're not ignoring those questions. We're not ignoring those comments. We feel your pain, and we are trying our best collectively to do something about it. So I suppose I just want to really think about this webinar today has been brought to you by a number of professional bodies. The big two bodies that three. We've got the Society of Vascular Nurses, which I'll always nod to as being a passionate member. But actually, the biggest two bodies that we've got today on this call is Legs Matter and Circulation Foundation. So can I just ask a specific question as a nurse in this field, both to Joe and to Niraj? How are you and your society is going to continue to influence the government funding and the priority within this specific field? Niraj, if I could ask you first.
Yeah, so I think it's imperative that we continue to reach out and engage directly with the MPs to try and express the importance of absolutely everything we've been discussing this evening. Stand in the MP shoes. They're exceptionally busy, have to consider such a breadth of topics. But what we need to be doing is when we get that really valuable time in front of them is have a really high impact interaction in a really short period of time to raise their interest in the subject and generate enough interest for them to learn more about it. And we've gone some way in doing that through our relationship with the Vascular and Venous all-party parliamentary group. So that's what we can do. And also, Martin's already touched on it, you have clinicians and community practitioners should shape the future. We can all talk about this passionately and therefore inspire others to feel the passion we do about saving lives and limbs.
Joe, and from a Legs Matter perspective?
Well, the Legs Matter currently, our strategy is looking at harm. So what we're looking to try and do is collect data to try and identify where harm might happen, but also to try and reduce the impact of harm. So while we're doing that, we're trying to collect people to join our Champions programme to try and actually have a one voice approach to shout out about actually there's harm being done in lack of access, there's harm being done in lack of understanding, raising awareness. So actually we really like to push this, gather you all together, bring you in as one group, part of our Legs Matter coalition, and then that one voice will have more emphasis, more push, more sway, and hopefully we can start to influence with all of our other organisations a change in the management for those patients living with PAD.
And that's why Legs Matters was formulated, if you like, to actually raise that collective voice, to make sure that we are shouting the same thing, because we've got more chance of making it happen. Martin, do you want to come in?
Yeah, I think we need to get our societies as well. You mentioned societies, the Royal College of Podiatry and the Vascular Society and the SVN. We need to be working collaboratively together on a long-term strategy for this within the influence we can all have collectively. And I think we've written a memorandum of understandings to work together. We need to build on those. And the Royal College of Podiatry, for example, have just released a position statement on all podiatrists having easy access to Dopplers and Sfigs, which isn't happening out there at the moment. And being able to influence at that level our members and support them to get kitted out to be able to be confident lower limb practitioners is going to be really crucial in this long-term battle.
Brilliant. And then my final quick fire question to all of you, and you can have a little bit longer if you require, is, so how do we keep this conversation going? If any of the people that's on the call today, what should they start to do tomorrow to help to shape this change, if you like, that we're all saying that needs to happen? Because I believe every single individual that's involved in this area is like a little mini Lego brick. And I do believe that if we all start to build in the same direction, we can make amazing, strong bridges. So Niraj, if I could ask you first, and you've gone first only because you're on my top left of my screen all night. So unfortunate, other people get a chance to have a think about. What do you think that people can do practically from this conversation today?
So you can be a leader and you can be an advocate in your hospital, in your primary care function as a patient advocate. There are lots of areas that look out for patient advocates to tell their story. So be a leader, be an advocate, understand how the service is provided in your area, and just work towards raising that awareness and raising the standard of provision. And that would be the thing for me. Be a leader, be an advocate.
And I would make that call directly to the patients. We, and many of us on this call, are formulating research to be able to look at how best to treat people going forward. It is no good formulating research from the view of the clinician or the nurse. We're not the person that's actually been suffering from this. So I'd like your voice in formulating research, because it's you, it's your disease. So if you are interested, if you have got one of these conditions, please reach out if you can spare the time, because honestly, we would love, and we are scrabbling around in the dark sometimes to get patients involved in that really initial stage of research. So please reach out. Jo, what's your take-home message?
Thinking about services provided, a collaborative approach, but also early intervention. So, independent practices, independent podiatrists, they're valuable in terms of trying to prevent disease, preventing it getting into the health service. But then how do we access into the health service? Where's that collaboration between private and NHS care? Because patients are accessing more and more services of their own intuition. And actually, so the front line, so the take-home message probably would be, how do we get better access, better communication? So maybe try and find your local hot clinic, like Jane mentioned, your quick access clinics, and see how you might be able to refer your patient from independent practice into the NHS.
Wonderful, thank you. So many people are already saying that they'd love to be interested from this point of view. How do you reach out? Legs Matter team, who's behind all of me this evening, please put the Legs Matters contact email on. If you just simply write them an email saying, for attention of Leanne, based on this, I will share with you my direct contact details, and we can be in contact about anything that we've discussed tonight. Not a problem at all. Brilliant, thanks, Jo. Jane, same question to you. What's your take home? What's the thing that they can start to action tomorrow?
So I think from a patient point of view, if you cannot access resources, if you do not have access to a supervised exercise programme, I think you ought to be making contact with your local MP. Those MPs have a voice in Parliament. They're part of our VVA PPG. They can be a collective voice from across the country to add strength and power to us pushing that in Parliament. So please, if you're a patient and you've lack of access, please shout out to your MP, get in contact.
And if you want help with that, both Shockwave and Legs Matters have some template letters that we are willing to share with you that basically you can send off to your local MP and to start pecking at the Swede, as they say up here in Yorkshire. So if you want any of those template letters, if you're just struggling with that, please again reach out to the Legs Matters contact. Martin, very quickly.
If you're a patient, I think work with your GP and practice nurses to understand your cardiovascular targets around blood pressure and cholesterol. Ask if you're on best medicines, if you've got known PAD, and if not, why not? And if you're a clinician and you're on this call today, we've got 286 people on, I think, at the moment. You're a PAD CLTI champion already, so you need to connect locally with your own teams more, and don't feel it's a specialist thing. You are the champion. So connect with your vascular teams, shadow clinics, connect with your leg ulcer teams, your podiatry clinics that are working with high-risk lower limbs, cross-connect and build strong infrastructure between yourselves.
Perfect. Mark, final words to you.
Okay, so patients, I would say, don't take no for an answer. If you suspect that there is an issue, then seek help and don't be dismissed. To my clinician colleagues, all I've ever wanted in my regional role across North London is the ability to have eyes and ears everywhere. What we need are those people in the communities who we don't even know to make contact, for us to get to know each other, and let's start building these networks, because we're not going to rely on the authorities to do it. We have to do it ourselves. Thank you.
And I would say, if you are a clinician out there, make friends with your local vascular surgeon. I can tell you all, they can all be bought with a latte and a piece of cake, every single one of them. They aren't scary cats. I can promise you they would welcome every single one of you to have a conversation if you've got a fear about a patient. So make contacts. You can always use your vascular nurses as an inroad if you need them. We have the special way of extra doubling cake to get you in front of them without a problem. So I just want to say thank you. Firstly, thank you to my esteemed colleagues. I love it when we bring together a perfect MDT to show that we're all on the same song sheet. I'd like to thank you, this audience tonight, both the clinicians for giving up your time to help to raise this, and to you as patients. It's your voice that we need within this sphere. This is why we're here. We need to change your outcomes. We need to improve the care. We need to give you access to the right care at the right time. So please link to the resources. Thank you all for coming this evening, and we wish you all a pleasant evening.